Good morning and welcome to our very first allergy education workshop. Today's session will focus on food allergy and anaphylaxis. My name is Megan Ahmad. Thank you for joining us this morning. I would also like to thank our sponsors for making this event possible. For any queries, please email admin@allergyfoundation.co.za. The recording of today's session will be made available to anyone who's registered, so please keep an eye on your inbox after the session today. Please allow up to 2 hours before trying to access the recording. Our program today will be led by an awesome panel of experts. For any medical professionals in the audience, please note that this webinar is not a CPD activity. Before we get started, I'd like to go over some basic housekeeping. This is quite important to ensure that you understand the icons on your screen. You will notice a taskbar in the top right-hand corner of your screen. It's currently indicated in the red box right at the top. Our audience is muted and will remain muted for the full duration of the webinar today, and we will not use the hand-up function. Instead, we encourage you to post your questions in the Questions tab. Our panel of experts will answer questions in this tab after the talks and during the short Q&A section at the end. You may use the React button to interact with the panel by sending your reactions. Handouts may be downloaded from the Materials tab. We are excited to launch this brand new series, which is specifically aimed at patients, caregivers, parents, and those wanting to learn more about allergy management. Our next session on 31 May focuses on rhinitis and conjunctivitis, or in layman's terms, hay fever and pink eye. Email admin@allergyfoundation.co.za for more information and to receive the registration link. Also remember to follow AFSA on social media and sign up for our free newsletter. Visit our website, which is www.allergyfoundation.co.za, to learn more about what we do and what we offer. Sign up for our free newsletter, browse our free downloadable content, and explore the products under the AFSA seal of approval. Visit the AFSA shop to purchase our in-house products, such as the AfriSpace device and the Kitty Calmware range of eczema clothing for kids. And lastly, before we kick off, I'd like to mention that we have 3 awesome prizes up for grabs today. One is a Beat Allergy starter pack, sponsored by Mrs. Martins. The other is an allergy book hamper with 500 Rand. And lastly, we have a Crystal Air Turbo HEPA air purifier unit valued at 3,500 Rand. Winners will be randomly selected and announced live at the end, so be sure to stick around. Before we get started, I would just like to grab your attention for one quick minute while I play 2 sponsor messages, in-house AFSA messages.
Looking for products that are safe for allergy sufferers? The AFSA seal of approval is here to help. This trusted seal is awarded to products that comply with our strict quality criteria. Look for it on body care products, air conditioners and purifiers, medical bracelets, nasal sprays and washouts, eczema clothing, cleaning products, and many more. Choose your products with confidence. Look for the AFSA seal of approval or visit allergyfoundation.co.za to view the available products.
Thank you so much for your attention. We are going to kick off with today's program with our first talk for the day.
Good morning, everyone. Thank you, AFSA, for inviting me to speak today. I'm really excited to spend this morning with you, and we'll be looking at the topic understanding food allergies. This is an outline of my talk for today, and I'll take you through all of the different discussion points. But before I start, I would like to show you a few images, and it just sets the tone for understanding food allergies and exactly how, the journey that people are on. So firstly, it's important, as there's, with the image of the magnifying glass, it's important to look in all the detail when you are food allergic and to understand that sometimes it takes a while, to get to all the answers. And that's why it's so important to spend sufficient amounts of time in finding the answers to optimally manage your food allergies. And then secondly, a food allergy diagnosis is not just as easy as a pregnancy test where you've got a yes or a no answer. It's really putting all the puzzle pieces together and then, to better understand your own individual food allergy. And then lastly, even though you might have a similar allergy to someone else, the journey that you're on is much different. And it's so important to understand and to remember that a food allergy journey is really individual. So food allergy occurs when your immune system mistakes a pretty harmless food for a harmful substance. So other people might be 100% fine without any symptoms consuming the same food that you are very allergic to. Your body then produces chemicals, for example, histamine, that causes symptoms. Now on your left, or to your left, you'll see an image of the most common food allergens that typically causes symptoms. And these 8 allergens are also clearly indicated on our South African food labels, which is Makes it a little bit easier for those living with food allergies to, for example, cow's milk or nuts. However, if someone is allergic to a food such as corn, for example, it's a little bit more difficult because it's not clearly indicated on the label as an allergen, and therefore it's so important to read your food labels. But we'll get to that as well. So you can be allergic to any food. It's not only these 8 that typically cause symptoms, and also it's important to know that so that if you find you have symptoms to something like, for instance, coconuts, that it is possible to have also a coconut allergy. Food allergies are on the rise, and it's globally the trend is on the rise, and that is really concerning. And there are multiple suspected reasons for this. So we know that food allergies affects approximately 2 to 10% of the population. And if parents are allergic, or there's a family history of allergies, there's an increased risk of siblings or of children also being allergic or food allergic. Cow's milk and hen's egg are the most common food allergies that we see in children, especially young children aged 0 to 3 years. And allergic symptoms or food allergic symptoms can range from immediate symptoms within hours to delayed symptoms, which can even present up to days later. Allergic reactions are reproducible. In other words, you're only allergic to a food when it happens, it reoccurs every time that you consume that food. If it's only been a reaction that occurred once and other times food is consumed with safety, then that is most probably not an allergy. So what we know about food allergy prevention at this point in time is that it's really essential for especially pregnant and breastfeeding women to consume a diet that is varied and diverse, a diet rich in whole grains and legumes and fruits and vegetables, not limiting a diet and especially not avoiding any allergens during pregnancy or during breastfeeding. What has come to light, and it's really good and sound research, is that early introduction of allergens, specifically peanut and egg, has a very good it's got a very good outcome in reducing the prevalence of reducing the chance of being allergic to those foods later in life. And the recommendation is to introduce as early as 4 months and no later than 11 months. Good skincare is also really important, and there's very good research also on the use of emollients during the early life and in the prevention of food allergies later on. What is also important is to limit your intake of ultra-processed food, because ultra-processed food that is typically high in sugar and salt and additives causes a disruption in the healthy microbial or microbes or microorganism composition in your digestive system, and that can also increase your risk of food allergies. So really looking at a wholesome and nutrient-rich diet. When we look at the difference between food allergy and intolerance, this is something that often causes confusion. So an allergic reaction involves your immune system, where a food intolerance is not immune-related. And a frequently asked question that I often get is, I've heard that lactose-free products are an option for my child with a cow's milk allergy. And the answer to this is no. A lactose-free product would not be suitable as a treatment option for a cow's milk allergic child. And the reason is explained in this table. When we look at a cow's milk protein allergy, it's a reaction to the protein in the milk, whereas a lactose intolerance is because of the deficiency of the lactase enzyme. In other words, there's an inability to digest lactose, which causes typical digestive symptoms such as abdominal pain, diarrhea, nausea, flatulence, and bloating. Whereas an allergy also typically involve other body systems, not only the digestive system. Symptoms in a cow's milk allergic child often occurs soon after birth, whereas it's very uncommon for a young child to have lactose intolerance. And then lastly, lactose-free products are not suitable for people with a true cow's milk protein allergy because the protein in lactose-free products are still intact. There's not been any protein that's been broken down in products that are lactose-free. Only the lactose as such has been digested, and they typically add lactase enzyme to lactose-free products, which makes it suitable for lactose intolerant people. And lactose intolerant people can then often even tolerate small amounts of yogurt or aged cheese, whereas cow's milk allergic people cannot. Another frequently asked question is, can food allergies affect my child's behavior? So let's look at allergy symptoms. Symptoms can range from mild to life-threatening, and that is something that is individual, and it's got different treatment plans as well. So symptoms can include the upper respiratory tract, typically including sneezing, running nose, congestion, and conjunctivitis. Also, symptoms such as shortness of breath, wheeze, coughing, or swelling of the throat. Digestive symptoms can include nausea, vomiting, diarrhea, stomach pain, and in children with proctocolitis, young children or babies, we often also see bloody and mucousy stools, and that is most often caused by cow's milk and soy allergy. We also often see food aversion or fussy eating, difficulty and pain when swallowing, skin symptoms such as hives and swelling, skin rashes and itching, and then also more severe symptoms, hypertension and lethargy. So yes, behavior can definitely be affected because of the discomfort and the emotional and social impact that is experienced by people living with these symptoms. Another frequently asked question, my baby or toddler is chronically constipated. Could it be food related? And the answer is also yes. It's important to, with the help of a qualified dietitian, to assess the child's fiber intake, fluid intake, variety of diets, and diversity of dietary intake, etc. But if all of those boxes have been ticked, we often see cow's milk as a cause of constipation in young children. So it's important not to rule out the possibility of a cow's milk protein allergy in chronically constipated children. So avoiding foods, when is it necessary? If you are allergic and you know that you're allergic to a food, it is very important to avoid that ingredient. But it's important to avoid only the ingredients that you're allergic to and to make sure that you're not unnecessarily avoiding foods that you're not allergic to. And that's why it's so important to consult with a healthcare practitioner before you start eliminating. I often find that patients visiting, breastfeeding moms, for example, that's been eliminating so many foods unnecessarily. And that is quite risky in terms of nutritional sufficiency because that mom becomes nutritional deficient very quickly. And quality of life really matters. So if you avoid food unnecessarily, it has an immense effect on your quality of life. So education is so important, and that empowers you and your family to best manage your food allergy. Is a little bit of the allergen safe? And this question is also really answered depending on the allergy that you are living with. If it's a mild cow's milk allergy, for instance, in a child, we actually recommend that to assess the tolerance of baked products like baked cow's milk, such as cookies, biscuits, and muffins. Because if a child with a cow's milk allergy can tolerate those, there's an also better outcome in terms of outgrowing the cow's milk allergy. However, if it is someone with a severe peanut allergy, not even a little bit of the allergen would be safe. And the same for a child, for instance, that lives with F pies. We know that those children often can react to even milligrams of the allergen. So the answer for safety would always be no, avoid the allergen that you're allergic to, but assess tolerance, and that is only done when you journey with your healthcare practitioner. So the cornerstone of food allergy management is to properly and thoroughly read your food labels. And the recommendation is to read a food label 3 times, once before purchase, once before storage, and again before consumption, because ingredients can be overlooked, especially if it's a product that's been used in your household for many months or many years even. Unfortunately, ingredients change, and they change without notification. So you might have used the product with safety, and then all of a sudden, an ingredient has been added, and it might be the ingredient that you are allergic to. So always please remember to read the ingredients, even though you know the product well. Also be aware of cross-contamination, the may contain section on the food label. The may contain has to be avoided in people with severe food allergy. However, people with mild food allergy might be able to tolerate those. And this is something that forms part of the education during your consultation with your healthcare practitioner. Learn the hidden names of allergens, because there might be an ingredient in a product, but it's under a hidden name, such as casein, for example, in a milk allergy. Now, the food allergic of the South African food allergy support app Allegro is a really useful tool, and it helps to reduce the burden of label reading and also to help the allergic individual discover a great, safe variety of food. When you dine or you go to a social function or you visit friends, it's important to ask about the ingredients in the product that's been prepared. Now, when you dine or you go to a restaurant, rather ask the manager instead of asking the waiter, because there might be a lack of knowledge as to what it means. If you would say, for instance, you're allergic to milk, they might tell you there's no milk, but then it's been fried in butter. So always rather speak to the manager. And also inform teacher or principal at your child's preschool or school. It's of utmost importance that they understand the severity of your child's allergy, also the management plan, and if necessary, the emergency plan as well. And what really helps is when you prepare as a parent, when you send a party pack to school containing all of the safe snacks that your child can consume. And in that way, if there are parties or unexpected treats, then your child would not be left socially isolated. And then also when you travel, you go away from home, always have safe snacks in your purse or in your car. It just makes it so much easier if there's an unexpected visit and your child or yourself are left feeling socially isolated. I won't go into detail into cow's milk protein allergy, but I want to touch on this because it's also something that we often see in practice, is that there's a big confusion regarding the suitable formula for children with food allergy, cow's milk allergy. So if a mom is breastfeeding, or if you are breastfeeding your cow's milk allergic baby, you might have to avoid cow's milk and cow's milk products. But that is also part of the discussion with your dietitian, for instance, or with your healthcare practitioner. If a formula is given, there's only really 2 types of formula that are suitable for a cow's milk protein allergy, and that is an extensively hydrolyzed formula that are tolerated by most children with cow's milk allergy, or an amino acid formula, which is only given to children with severe cow's milk protein allergy. If soya is tolerated, soya formula can also be given. However, some cow's milk allergic babies might also have a reaction to soy formula, so this should be discussed with your healthcare practitioner. It's not suitable to give a HA milk. It's not the protein has not been broken down enough for that baby to recognize it as safe. So it's not an option for a treatment of a true cow's milk protein allergy. And also goat's milk or other mammalian milk, the protein structure is very similar to cow's milk, and therefore it's not suitable. And of course, as I've said before, lactose-free products or formula is not an applicable formula for a cow's milk allergic baby. So what is a food challenge? Now, in most IgE-mediated food allergies, or people with severe, especially children with severe non-IgE-mediated food allergies such as F pies, it's a process or a procedure that's done in a medically supervised environment where the food allergen is reintroduced safely. Or at least it's evaluated if that food can be reintroduced safely. It contains a repeated small amount of allergen that's given in increasing amounts, but please always remember this cannot be done at home. And in this way, the healthcare practitioner can determine whether the food allergy persists or whether it has been outgrown. So how to manage mild food allergy? So firstly, any allergy has to be, or any allergy has to be managed by avoiding the allergen for a time. And that period it will be discussed with your treating physician. And then safe reintroduction can be planned a few months later. And if it's, like I've said, in mild food allergies or mild IgE-mediated or mild to moderate non-IgE-mediated food allergies, it can be done at home. But of course, always first discuss it with your healthcare practitioner before starting the process. So there are ladders available. To your right, you'll see the milk ladder, which we often use in practice. But first, I want to again remind us that food should not be introduced at home if there's a history of severe reaction or in people with asthma or children with FIs. Okay, so if it's been discussed that it can be done at home, the milk ladder, egg or soy ladder is a stepwise process, and it's also done over a period of time where certain forms of that protein, especially the first step would be a more broken down form, a baked form of the protein is introduced first, and then you literally climb up the ladder and evaluate what form of milk would be tolerated, and hopefully, all the steps can be followed through, and especially when a child has outgrown food allergy, they will be able to tolerate full cow's milk. It helps to complete a food and a symptom diary during this process, because in that way you can identify any possible symptoms that might occur at any step. And if symptoms present, then unfortunately the ladder has to be stopped, but then we re-evaluate again 6 to 12 months later. If we look at outgrowing food allergies, so most food allergies are outgrown during childhood, especially cow's milk, egg, soy, and wheat. However, unfortunately, some nuts and tree nut, peanut and tree nut allergies might persist into adulthood. You are not alone, and I can't emphasize this enough. Research has shown that good education and good emotional support really improve the quality of life of families living with food allergies. And AFSA provide wonderful support groups that you can join. And also, if you feel that you need more emotional support, you can be referred to healthcare practitioners that are experienced in offering the support that you need. Also, to be empowered and educated in that way, you can also educate your family and friends and ask them to also support you, which is really important because it's a very sometimes lonely and isolated journey. And having support just makes the world of a difference. So to conclude, it's important to know what you're allergic to and to understand the ingredients, and also to understand your reaction and the severity thereof. Understand and read food labels carefully, and don't underestimate the importance of this. Remain vigilant, especially because ingredients can change without any notification. Follow up with your healthcare practitioner every 6 months if it's a young child, and every 12 months in older children and adults. And this is so important because we often see that allergies or allergens are avoided for longer than necessary, where the child, for instance, could have enjoyed a food, many months before. So don't forget to schedule your appointments in time. Visit a dietitian to ensure optimal nutrition, because there's a big risk for nutritional deficiencies when certain food groups are avoided, and a dietitian can help you to make sure that your diet or your child's diet is nutritionally optimal. And then carefully evaluate the accuracy of information available on social media platforms. It's better to ask a healthcare practitioner, and especially if you join the support groups, the AFSA support groups, you can ask questions on that platform and a healthcare practitioner will answer. Because unfortunately, there's a lot of misinformation online, which causes a lot of confusion and oftentimes unnecessary avoidance with really severe nutritional implications. Thank you.
Okay, cool. Hi everyone, I'm Peter de Waal. I'm going to talk to you about identifying and treating anaphylaxis. I think it's a very important topic. So we're talking about a life-threatening reaction here, so it's important to identify it and treat it effectively. So let's first look at what is anaphylaxis. So according to the World Health Organization, anaphylaxis is a severe systemic hypersensitivity reaction, so it can be severe and systemic. Often we see more than one body system being involved, and it's usually rapid in onset. It develops within minutes to a few hours of being exposed to your allergen or a certain allergen or highly likely allergen. And it's important to remember that it can be potentially life-threatening. You can potentially die from an anaphylactic reaction, especially if it's not recognized and treated immediately. Airway and breathing, as you all know, your respiratory system or your breathing system is very important. And if these systems becomes compromised, you can actually die from anaphylaxis. Usually, although not always, it can be associated with skin or mucosal changes. But it's important to remember, not always. It's not always necessary to or needed to diagnose anaphylaxis without skin problems. So early identification of anaphylaxis is important and crucial. It has been recognized in clinical studies that most deaths from anaphylaxis is due to people not recognizing anaphylaxis early enough. So patients, teachers, caregivers, even doctors doesn't recognize anaphylaxis, and it then there's then a delay in symptom onset until the treatment is started. And there's still uncertainty, or a lot of people are still uncertain of when, how, and which medicine to administer during a reaction. So the diagnosis of anaphylaxis is purely clinical. So clinical meaning you don't need special tests and special investigations to diagnose it. Often we just make the diagnosis by taking a good history. It's obviously important, it's mandatory. And in most cases, that history will then point to minutes to hours after exposure to a known or a likely allergen. So if you are known to be a bee sting allergic, your history will obviously point then that you've been stung by a bee and then you developed within minutes or hours develop symptoms. A likely allergen, we'll go through the causes of allergy in a moment, but a likely allergen is then an allergen that has been pointed out or has been highlighted as an allergen causing allergic reactions all over the world. So what are known or likely triggers of anaphylaxis? Well, on top of the list is probably foods, and on top of that list is probably egg whites. Remember, not egg yolk. Egg yolk is not really considered to be allergic, and in most instances when it comes to egg allergy, egg white is the culprit. Then we have our legumes. Peanut is probably the best known allergen, and then tree nuts, and then the whole family of tree nuts can really be implicated here. Milk, cows and goat's milk. So remember, if you are allergic to cow's milk, avoiding goat's milk, all sorts of mammalian milk is important. So goat's milk should also be avoided. Fish, and that includes shellfish. Seeds like sesame, pine nuts, mustard, fruits and vegetables. A rare cause, we've had the question just now, how common is vegetable allergy or anaphylaxis? It's actually fairly rare unless you have a cross-reactive syndrome. Mammalian meat has been recently highlighted. That's where you react to red meat, and it's been established in conditions like alpha-gal syndrome. And then we often have we also have an allergic reaction called food-dependent exercise-induced anaphylaxis. And here wheat, specifically if you eat wheat 4 to 6 hours before you do exercise, then you develop an anaphylaxis. So the two apart doesn't really produce problems, but the moment you combine the two in a short amount of time, then that can cause an allergic reaction. Other known or likely triggers are medications. So we probably know about penicillin. So penicillin, unfortunately, it's been completely overdiagnosed. Often we diagnose penicillin allergy just based on a skin rash. So it's important, if you think you are allergic or had a possible allergic reaction to any antibiotic, but more specifically penicillin, get yourself tested, because penicillin is a good antibiotic, a very effective antibiotic, and we should delabel patients that hasn't formally been tested to penicillin. Other non-steroidal anti-inflammatory drugs or pain medication, drugs that's been used or that are being used during surgery, the so-called perioperative time, or drugs, opioids, and even intravenous iron can cause allergic reactions. Then a common or a well-known cause of anaphylaxis is honeybee and wasp stings. And then there's also occupational allergens like wheat, for instance, in bakeries, or fish causing allergic reactions in fish handlers. Latex, so fortunately all our hospitals are doing their best to become latex free, but in some instances latex allergy has also or are being reported. And then unfortunately there's a fairly rare condition known as idiopathic anaphylaxis, where you just have anaphylaxis without an apparent cause. So there are certain cofactors for anaphylaxis, certain conditions that if you are exposed to a known or likely trigger and have this underlying condition or being exposed to this underlying or environmental situation, you can develop anaphylaxis easier. So it decreases then your threshold for developing anaphylaxis. So you develop anaphylaxis in conjunction with one of these situations or conditions. In children, we know that acute infection, often just a viral infection, can make you more prone to develop anaphylaxis, where if you don't have any infection, you don't develop an allergic reaction. Exercise, like we've just said, travel, menstruation, extreme temperatures, so often hot temperatures, but also cold temperatures. And in adults, it's also been identified that alcohol and intake and sleep deprivation can also cause or act as a cofactor and develop or lower your threshold for developing anaphylaxis. Then there are also certain factors that may lead to a worse outcome when you're having an anaphylactic attack, and that's usually infants, because infants often cannot tell what's wrong and what they are experiencing. So anaphylaxis is often missed in these age groups. Adolescents, because they often embark in a risk-taking behavior and experiment with all sorts of things. So the elderly, often because they often have multi-system involvement, like respiratory or cardiac or heart problems, and then the pregnancy state or being pregnant, because you and your baby's lives are at stake here. Then there's other concomitant or underlying diseases that can make your anaphylaxis outcome worse. Asthma, other respiratory conditions, we'll talk about that in a minute. Psychiatric diseases, like for instance depression. Mast cell disorders, where your mast cells become a bit twitchy and overreact to often things that they should not be overreacting to. Underlying heart conditions, like a previous heart attack or blood vessel problems. Allergic rhinitis and atopic dermatitis are also important conditions to remember here. So let's recognize a patient with anaphylaxis. So first of all, we'll often have the history of being exposed to a known or highly likely allergen. Going through that list that we just talked about, we have our time span from exposure to developing symptoms, and that's often within minutes to a few hours. Often an hour or two has been reported. And then it's really a multi-system disease, and you can often have multi-systems being involved all at once, or you can just have one specific system that's being involved. So let's look at the skin. The skin are a common manifestation of anaphylaxis, especially early signs during the early stages of anaphylaxis. But remember, you can also have anaphylaxis without any skin manifestations. So here we have redness, flushing, urticaria, swelling of the lips, swelling of the eyes, swelling around the eyes, called periorbital edema. Airways and lungs, these are life-threatening systems. You need oxygen to breathe in oxygen to stay alive. And often these can manifest as noisy or a high-pitched breathing sound, coughing, wheezing of the chest. Patients often describe a tight chest. A hoarse voice can be heard. And then you can often just have a nasal stuffiness. Patients complaining of their nose becoming blocked all of a sudden, or the nose can be runny. Gastrointestinal symptoms, like Idanet just mentioned, abdominal pain, cramping, nausea, vomiting, all of a sudden developing diarrhea or loose stools. Cardiovascular symptoms, and that's specifically when your blood pressure starts to drop. You can faint, or you can lose consciousness, you can feel kind of funny, or you can complain, or patients can complain of chest pain. The mouth can also be involved with itching of the lips or the tongue or the palate, and the eyes are often seen early in allergic reactions where the eyes becomes red, they become teary, and they start to itch. So these are just pictures that I took in my practice of patients that suffered allergic reactions. And thank you to the mums that gave me permission to share these with you. So on the left side, that little girl has only cutaneous reactions after first exposure to egg white. So she started eating egg, and within minutes after starting to eat egg, scrambled egg in this case, she developed this red itchy rash around her mouth. And that's called a periorbital rash, very common in certain foods like milk and egg allergy. That's not anaphylaxis. That's a cutaneous or a mild manifestation of an allergy. We'll talk about that in a second. So it's important to distinguish between just a mild allergic reaction versus anaphylaxis, because you're not going to treat the two completely the same. Then that girl in the middle, she's been stung by a bee. She's now about 7 or 8 years old. Her first episode of being stung by a bee. On the left-hand side, early in her reaction, you can see how quickly she progressed. On the left-hand side, a bit of swelling around her lips or of her lips and swelling around her eyes. And then quickly, within minutes, she developed shortness of breath and her chest started to wheeze. You can see her eyes starting to become more puffy, and she needed oxygen. And that's called anaphylaxis. So in the beginning, she just had mild symptoms, which quickly progressed into a life-threatening respiratory compromise. And then also urticaria or hives or welts that we often see in the early stages of an allergic reaction. So an important question that you guys need to answer when you deal with someone or have a family member or you yourself have the potential to suffer from anaphylaxis: is my reaction only mild? Is it only a mild allergic reaction? Or do I have an anaphylactic attack? Do I have anaphylaxis? And that's classified as a severe allergic reaction. Mild reactions, especially early stages, would be then only swelling of the lip, face, or the eyes, abdominal pain or vomiting, hives or welts, and then a possible tingling sensation around the mouth or around the lips. That's a mild allergic reaction. Severe allergic reactions might follow mild allergic reactions, or mild allergic reactions may progress into a severe allergic reaction, also known as anaphylaxis. And these are your severe anaphylactic signs or allergic reaction signs: difficulty or noisy breathing, swelling of the tongue if your airway becomes blocked, you can't breathe, tightness of the throat, a wheezing or a persistent cough, difficulty to talk or difficulty speaking or a hoarse voice, dizziness or fainting. And then in small children, we often see floppiness or becoming pale as an early sign or a sign of an anaphylactic attack. So what to do when you recognize that you're having a mild allergic reaction? I think it's important to stay with the person and shout for help. Do not try and treat this condition alone. Shout for help. Shout for the teacher. Shout for other friends. Or it's important not to be alone when you're treating these patients. If that patient has an adrenaline auto-injector, we'll talk about that in a minute, locate it. You're not going to give it at this stage, but you just should know in case this allergic reaction then progresses or escalates to a severe allergic attack. Then you give your oral non-sedating antihistamine. And it's important here that you give an antihistamine only to treat the hives and the itching and the redness and the flushing. It's not really going to help, or not going to help at all, in a severe allergic reaction or anaphylaxis. It's important also to use a non-sedating antihistamine. You don't want to give something to a person that's going to make them sleepy or drowsy. Otherwise, this may actually mask that patient's level of consciousness, and it will be more difficult to see whether that patient actually is progressing and that patient is losing consciousness. And then the fourth step would then be to phone an emergency contact person. So in all these 4 steps, remember, it should be done promptly, it should be done quickly, and often we do that all at once when we treat a patient with a mild allergic reaction. The treatment of a severe allergic reaction or anaphylaxis, once again, stay with the person, but now because you're scared of your blood pressure being dropped, you're going to ask that patient to lie either on the side or lie flat. And in some instances, you can also ask them to lift their legs up so that there's increased blood return to the heart and to the brain. And then once again, shout for help. Immediately after you've diagnosed a severe allergic reaction or anaphylaxis, give adrenaline as soon as possible. It's not really going to help to give an antihistamine at this stage. You're going to have to give adrenaline as soon as possible. Call the ambulance, and it might not be a bad idea to do a basic life support course if you know someone or you yourself is suffering from anaphylaxis. And then after that, or soon after that, you phone that person's emergency contact person, like for instance a parent or a family member, and that patient should be transferred to the hospital. So how to administer your adrenaline auto-injector? So make sure your auto-injector has the correct dose. So we normally say from about 4 to 25 kilogram, we give the EpiPen Junior or the 0.15 milligram. and roughly it's about 0.01 milligram per kilogram body weight. And then if you're weighing more than 25 kilogram, 0.3 milligram should be given. Generally, 0.5 milligram is the maximum dose given to adults. Your next step after you've located your epinephrine or adrenaline auto-injector is to remove the blue cap. Otherwise, your EpiPen is not going to work. We tell patients to hold it like a dagger. Remember, the one end of your EpiPen is having a needle. So the moment you push that one end, the needle is going to come out, and you don't want to prick yourself with a needle or inject yourself with adrenaline. And also remember, there's only one dose in your EpiPen. So we tell patients to hold the blue side to the sky, so blue to the sky, and the orange side should be into the muscle or to the thigh. Then you swing it, or with a slight swing motion, you give a deep injection into the muscle. So we call that muscle the vastus lateralis muscle, or the thigh muscle. You push it as hard as possible until you hear a click. And then when you've heard the click, you hold it in place for at least 3 seconds, anything between 3 and 10 seconds. Remember, there is a subset of patients that may actually need a second dose of adrenaline. And because you only have one dose in one EpiPen, that patient needs to be transferred to hospital as soon as possible. So general guidelines say you can repeat or should repeat your auto-injector at least every 5 to 15 minutes when your patient has ongoing symptoms. So adrenaline is really the drug of choice when it comes to anaphylaxis treatment. Remember that antihistamines may relieve skin itching and hives and flushing, but it's not useful to treat anaphylaxis. Anaphylaxis may be present in the absence of skin symptoms like we've said. Intramuscular adrenaline should still then be given. And then really corticosteroids, prednisone, aspilone syrups is not useful. It simply takes too long for these drugs to work, and it's not useful in the management of anaphylaxis. For asthmatic patients, adrenaline should also be given first, and then your reliever pump should be used. So once again, even if you are an asthmatic, and even if your chest is tight and you start to wheeze, give your EpiPen or your adrenaline auto-injector first, and then use your rescue or reliever pump. So let's summarize. I've had an anaphylactic attack, or I've had anaphylaxis. What to do now? So generally, when you land up in hospital, observation time of anything between 4 and 6 hours will be needed for you for doctors or sisters to make sure that you are actually safe and stable and can be discharged home. Then you're going to have to be referred to an allergy specialist, or at least someone that has a special interest or knows about allergy or allergic conditions. And this person will start off by taking a good history. You cannot really treat any patient with allergies without taking a good history. After that, skin prick tests or IgE blood tests to confirm a specific allergen will most likely follow, and that's basically on after your good history has been taken. So it's not a good idea to do blanket testing, do blanket allergy testing, ask for a whole panel of allergens if you are sure you're only suffering from a specific allergen. Then you should do specific blood tests to that allergen in question. The next step is then to be educated. So you're going to spend a few minutes or an hour or two with your doctor, and that specialist is then going to tell you what anaphylaxis is, how to identify it, and then obviously how to use your EpiPen. So it's important to have a physical demonstration on how to use an EpiPen. Otherwise, if you're having an anaphylactic attack, you might find it very difficult if you've never seen or touched or held an EpiPen before. Other requirements is then an anaphylaxis action plan, which Prof. Mike will talk to us about, an allergy alert bracelet, so that everyone around you or who knows you know that you are certain or you have a certain allergy and may suffer from anaphylaxis. And then the last step is then to improve asthma control. We've now seen that asthma is an important concomitant disease that may actually decrease or make your asthma or anaphylactic attack or outcome worse. So it's important if you suffer from asthma and anaphylaxis to get your asthma under control. Allergen immunotherapy may follow. So we also have the option of oral allergen immunotherapy, where we give that small amounts of oral food or food to that specific patient over several months or years. And it's important, like Idonet also mentioned, adequate follow-up with your healthcare practitioner or your allergist is important. And then obviously allergen avoidance as far as possible by doing label reading and making sure you're not being exposed to that specific allergen. An important aspect in treating anaphylaxis is to get everyone involved, family members, caregivers, and friends. Everyone should know that you have the potential to suffer anaphylaxis or from an anaphylactic attack at all times. Deaths often occur at school, in children, and at restaurants, specifically in adults. So it's important that most reactions happen at school. So what should we do in the school environment? I think it's important to have an individual file and an anaphylaxis action plan for each child. So your teacher should also, or sports coach or school staff should also know that a specific pupil has a severe allergy and may actually have an anaphylactic attack. They should be trained how to use an action plan and how to use an epinephrine. And like I said, a basic life support course is not a bad idea. Restaurants, it's important to make sure that staff are aware of recognizing anaphylaxis and adequately train how to treat anaphylaxis. And it's important that staff should also remember that cross-contamination, specifically in seafood restaurants, cross-contamination between fish and, for instance, shellfish, is a big problem. and these should be kept in mind specifically during food preparation. So to take home, anaphylaxis is potentially life-threatening. It should be recognized early, and immediate treatment is important. Mild early reactions, where only the skin is involved, you can give antihistamines, specifically at home, where you see there's only early signs of a reaction. But when you see or recognize there's anaphylactic signs, call for help, give adrenaline, and make sure you get to the hospital as soon as possible, because you may actually need a second or a third dose of adrenaline. It's important that all patients who've suffered from an anaphylactic attack should be seen by an allergy-trained doctor as soon as possible. They should have an action plan, adrenaline auto-injector, and an allergy alert bracelet. And the whole family, caregivers, teachers, and restaurant staff, and general public for that matter, should be aware of anaphylaxis. They should be trained on how to recognize it, and specifically how to give life-saving adrenaline. Thank you.
Good morning, everyone. And I'm really happy to be joining you here today and loving all of the questions that are coming up. I'm struggling here to keep up to date, and just really excited to see everybody is here and engaging with this topic. So I'm going to be talking a little bit about the patient resources that are available for food allergies anaphylaxis. And really that's a story for AFSA. The whole reason for existence is capsulated here in our mission statement that we try to save lives, improve quality of life, and reduce the cost of healthcare for all South Africans who suffer from allergic disorders and primary immune deficiencies. And we do that through running this nonprofit corporation, which is a public benefit organization. And you can find out all the information that I'm going to be telling you about now on our website, www.allergyfoundation.co.za. And there are lots of things on that website. There's an allergy professional search tool that I've been putting into the pointing towards as the answer to a lot of the questions that are coming online, because the questions are really quite complex and they need somebody who understands allergy and knows about it to answer those questions. So if you do have unanswered questions at the end of this webinar, and many of the people that we've said do need to find an allergy professional, there's a search tool online that you can type in even the different potential condition you have. There have been questions about alpha-gal, there have been questions about rare allergies. So you can type in the condition that you got a question about, the region that you're looking for, the type of practitioner you want, and you can find people in your area who will be able to help you. We've also got social media and newsletters, and you can sign up our newsletters very easily by emailing admin@allergyfoundation.co.za. We've got allergy safe products that you saw in the videos at the beginning, the Learning Academy, and support groups. What I'm going to focus on for the next couple minutes is the downloadable resources that are available on the website. And they are huge amounts of downloadable resources. And they cover a lot of the area of conditions that we've been talking about, and they answer some of those very important questions that Internet was raising. And so, for example, the very basics about what is a food allergy is contained in 3 different brochures online. What is allergy, about food allergy directly, and delayed food allergy. And really the key messages from all of that have been covered already is that not all adverse reactions to foods are even a hypersensitivity. There are other things that can cause reactions to foods, like there's a toxin in the food and you get food poisoning. And then even the food hypersensitivity, some of them are allergic, like the things that Peter was talking about, having to treat with severe versions of anaphylaxis. And some of them are not allergic, like the lactose intolerance that Internet was talking about. So food allergies, we stress, are an immune-mediated food hypersensitivity. There are the 2 major different types, the immediate and delayed type hypersensitivity, and we've really only focused today on the immediate type food allergy and listed the various different signs and symptoms that people can get and the various different things that can cause these symptoms. So again, we have a pamphlet and a brochure on every single one of those particular allergies that you could be having there. So hopefully there's something for you specifically. We do know, as Internet pointed out, that there are people who are allergic to very rare things, including we had a question about garlic, and we've had questions about, weird and wonderful things. Absolutely, that can definitely be the case, but hopefully we'll find something for pretty much everyone if you search for your particular condition on our website. There's also been a lot of questions already about one allergy leading to another allergy and the relationship between food allergy and other types of allergy. So again, we can answer all of those questions from information on the website. There have been a lot of questions about preventing allergy. Yes, folks, definitely pregnant women should eat all foods, not avoid any particular food. It's definitely not recommended. And then for any of those conditions that you could have either along with or as part of your condition, there's information about that online as well. Internet stressed that we do not want everybody on this webinar to come out from this thinking, oh, I might have an allergy, now I must avoid this thing. Only avoid allergens if you're allergic, if you've definitively been proved to be allergic to that thing, because unnecessary avoidance causes problems, including the possibility that it might even make you allergic. I know that sounds weird, but avoiding foods unnecessarily when you should be eating them and learning how to deal with them when you're a baby is one of the major causes that people now have so much food allergies. The other reason allergy testing is confusing. And there are a lot of questions online already about allergy testing and how do I really know whether I've got an allergy or not. So again, please look at the brochures on allergy testing, allergy skin tests, and food challenge tests. And to just kind of, again, extract a couple of the highlights from that concept and why it's so important that you read those brochures is because skin and blood tests show sensitization. They show whether there's a little bit of an antibody present that could be causing an immediate type reaction or whether there's a lot. But most people have some antibodies. So just having a tiny little bit of a raised level or a little bit of a bump on your skin prick test does not mean that you have allergy. It just means that there is a non-zero percentage chance that you've got allergies. If there's no bumps there or the allergy test is completely negative, then you do not have an IgE-mediated food allergy, at least. But many times with these blood tests or skin prick tests, we are still not able to tell 100% for sure. And like we said, avoiding food for no reason is a problem. So we have to go on to do what is called a food challenge, where we give a little bit of a food in increasing amounts in a very controlled setting. This is done to 100% prove if the allergy exists or if it persists or if it's gone away. But again, you need to do this safely. This is usually done in this is only done in a medical environment. And you need to have a specific doctor who is able and willing to do this. Again, referring you back to the list of allergy specialists. If people are doing and diagnosing food allergies in you with just skin and blood tests without doing food challenge testing because they do not have the possibility to do it, then they're not the right doctor to be dealing with this problem. We've discussed what anaphylaxis is, and we've got anaphylaxis brochure. We've got an action plan for anaphylaxis, a slightly different version for venom and anaphylaxis, and we've got a poster for hospitals and clinics to how to manage the long-term or more in-depth management of anaphylaxis. So Peter has explained to you about anaphylaxis and what it is and how it's treated by calling the emergency services, using the adrenaline injector, and then if symptoms persist, use a second dose and wait for additional medical care. And as he's pointed out, the additional treatments apart from the adrenaline injector are supplementary treatments and do nothing for the underlying problem. So they can be used if the problem is mild, but they are not a treatment for anaphylaxis. And this little extract here, this picture comes directly from our brochure that explains the steps that Peter has explained to you. And this is our newest version of the anaphylaxis action plan that you can also use and give out to children to give to their teachers at school. We've also got other resources. We've got this AFSA chef card, which carries around so that you can give it to the chef and tell them, listen, I'm serious about this. And my doctor has agreed that this is a severe food allergy. This is not play that I'm talking about. We have other resources in that we have a partnership with ICE tags to have these amazing allergy bands, which are very structurally sound and very, very attractive. You can also order these online through our website at the online shop. For those of you who've got asthma, also please be aware that a combination of asthma and food allergies is dangerous. So if you've got asthma, it's got to be perfectly controlled. Every single patient with mild to moderate asthma who is a child or who has a food allergy, or any children with severe asthma who are, not children, any adults with moderate to severe asthma who are on combination therapy, you should all be using a spacer with your metered dose inhalers. If you're using a pump, it should be in a spacer. If you're using a dry powder inhaler, that's a different story. But if you're on a pump, you should be having a spacer. Please get hold of an AFRI spacer. They're also available to order online. We've also got, for people who've got eczema, our own invention of clothing, which is hypoallergenic, seams on the outside, special material, and this can be used to treat eczema by wet wraps, which otherwise the only alternative is to try repurpose clothing or to make it with tubular bandages, which is very much more complicated. So you can also get kiddie comwear. So I want to thank you, but also before I finish, to answer a question that I've been asked again a couple of online times is what should I be doing and what can happen in my community? So I think in answer to that, please get involved in patient advocacy and in school advocacy. In particularly around the school issue, please pressurize the teachers of your schools and your headmasters or head staff to make sure that there is a plan in place for your child that includes knowing how to look for anaphylaxis and deal with anaphylaxis with injectable adrenaline, and that they are able and willing and prepared to do that, rather than getting all obsessed with the peanut in schools issue, because it has been shown that avoiding peanuts in foods is ineffective and gives schools an excuse not to do the thing that is more important, which is to make sure that your kid is safe. The third thing I'd want you to do is to sign up. Just send an email right now to admin@allergyfoundation.co.za asking to sign up for more info and to be on the newsletter list to get more information. Please, if you're a member of the Woolworths My School, My Village card, go online right now, click that button that says select the Allergy Foundation South Africa as one of the 3 beneficiaries that you are allowed to select. So I don't want you to take everything away from the pets or from your school. I just also want Allergy Foundation to get a little bit of that pie, pretty please. And then finally, please tell your friends about the next webinars, because we've got webinars coming up, and I'm sure those times will be shown again on asthma and on hives and on eczema, which are many conditions that also you or your friends will also have. So with that, thanks. And I think we are going into questions, which I'm going to ask either Idanet or Peter or both of you to kick off with, because of getting things, technology back into place.
So Yvette is asking, I once had a severe reaction to eating mushrooms, mostly gastrointestinal. It seems like she vomited.
Yeah.
She had vision disturbance, severe migraine. Is it a known allergen? Should I try it again? And she always keeps the celestamine at hand, but it doesn't seem to be available all the time. And what's the medication for a milder reaction?
Okay, so it's an awesome question, and thanks, Peter, for pandering to my very weird interest in mushrooms and fungi. So yeah, very, very like appropriate question. The true mushroom allergy, IgE-mediated reactions to mushrooms are very, very, very rare. But mushrooms do contain a whole bunch of other substances that need to be broken down by the body. And some of those substances, various different individuals have either higher levels or lower levels of the enzymes that break them down. So some people have intolerance reactions to mushrooms that are the same regularly all the time with that particular species of mushroom even. But that's not an allergic reaction, and it's not going to spill over and cause like, hives or anaphylaxis or anything like that. So I would say that that's very, very likely what it is. The other thing that I want to just pick up is that you said something about treating it and carrying around celestamine. There's another question here about what non-sedating antihistamine would be recommended for a child with nut allergy when they get a mild reactions. The important thing, and then mentioning 2 trade names, neither of which I actually think are non-sedating antihistamines. So please, guys, when you're using an antihistamine long-term for hay fever or rhinitis or urticaria, it's got to be a non-sedating antihistamine. And when you're using something for an emergency reaction like anaphylaxis, it's got to be a non-sedating antihistamine, because you don't want to put somebody to sleep when they're having an allergic reaction. So the actual drugs are, the molecules are cetirizine, levocetirizine, loratadine, desloratadine, rupatadine, fexofenadine. Those are the names, but please make sure that it's a non-sedating antihistamine that you're going to use in that circumstance. So I do want to pick up on this question from Catherine Wirth, because it was asked right now. I just want to make sure that I've understood. If I've had skin prick tests and then blood tests, do I still need to see an allergy specialist to do food challenges to 100% confirm my allergies? Catherine, the answer is, it is in all likelihood that you do need to see an allergy specialist to interpret the skin prick tests and the blood tests along with the history. Because like I've said, it's very likely or possible that many people will have some level of antibodies, and most doctors do not even know or understand this. And they will say, well, you complaining of, I don't know, tummy pains because of eating mushrooms, right? Like the example we've just had. And now I've done a blood test for mushrooms and it shows a level of like 1.3. That must mean that you're allergic to mushrooms. Now avoid mushrooms for the rest of your life. And that's not the way that those tests work. So absolutely, that allergy specialist may or may not need to do a food challenge. But at the very least, I do believe that people who do allergy tests should be able to interpret those allergy tests and be able to do food challenges if necessary. Because otherwise, how do you know that they're not saying that you're allergic to the thing because they can't do the food test, or because they're actually 100% sure? So yeah, please make sure that you get somebody who has skills and experience to deal with food allergy. Peter, are there other questions that you want to add up so I can get off my soapbox or highlight Internet?
Hi, Mike.
Yes,
yeah, what are you picking up, Internet?
Well, I've just read a question from Boitamelo that says, my now 6-month-old vomited 2 different brands of formula. Does it mean she's allergic? So I think that would also be a question that we need to answer.
So go for it, Internet.
Okay, so firstly, it depends on the type of formula. So if cow's milk formula, for instance, was consumed previously without any symptoms, then, sorry, I see an answer came through. Yeah, if cow's milk formula was consumed previously without any symptoms, then it's, of course, cannot really be the formula that causes symptoms. It also depends on other possible introduction of solids that happen during that time. So just always make sure whether it's the formula or whether it might be a food that was introduced or any other cause. Like we've mentioned in the talk as well, it needs to be reproducible. So if you noticed vomiting after giving a formula and it happened again, and it was, for instance, a new type of formula that wasn't previously given, then it's definitely possible. So I think we need a bit more information to better answer your question. And the food and symptom diary really helps, especially when you introduce food to a baby. You can, if you notice some symptoms, start writing down so that you can identify if there's a pattern in the type of food that you give that aligns with the symptoms that you see in your child.
Thanks, Internet. I'm going to pick up on a question that has come through from Cherie Nicole that says, my daughter's been tested for allergy and we did the skin prick tests and blood tests and it has come up that she does not have allergies they tested for. But when they test, there's always histamine that is high, so we just give antihistamines. Cherie, I think what you are referring to is the histamine test that is done as part of the skin prick test. And that histamine test that is done as part of the skin prick test is not a test to see if you're allergic to histamine. It's putting histamine into your skin to make sure that your skin is able to react to histamine. In other words, for us to check to see whether if we put allergens in your skin that you're allergic to, it's going to work. Is this test of good enough quality or not? Every single person who has that histamine skin prick test will get a bump to the histamine. If they don't, it's because they've been taking antihistamines and the test is invalid. But it's not a test to see if you are more sensitive than not to histamine. The fact that the skin prick tests and blood tests came up not for allergies means you're not allergic to those particular foods in the form of an IgE-mediated reaction. There's no realistic chance that you're allergic to those particular foods. It also means that your doctor didn't explain to you what the tests were and how they worked and let you have this misconception. And yeah, that's unfortunate.
Then there's
So-
another question. Yes?
No, you
Yes,
can go,
Eden.
Peter.
I just see there's an important question here. Is it necessary to use the EpiPen on the thigh only? And the answer is absolutely yes. So that's really the only muscle that has predictable sort of effects once adrenaline has been injected. So the thigh is the only recommended place and muscle where EpiPen or adrenaline should be injected. Yes, Idunette?
Okay, there's another question. How accurate are skin prick tests? My son, 10-month-old, reacted to dairy, egg, peanut, and cashew. Should I do further testing, avoiding all these allergens and climbing the milk ladder slowly? So if you want to be too, could perhaps answer.
So am I getting it right that the tests, that those allergies were diagnosed on sensitization only?
Well, from the question, the only test she mentioned was skin prick testing, yes.
So again, we got a problem here that maybe this person has food allergies to those things, maybe they don't. It's possible that there was a very strong history suggestive of food allergy, like Idanet has said, that is reproducible, is typical in terms of its symptoms, and there is very high-level antibodies, and that a very, very good doctor has decided this is definitively food allergy and you need to avoid these things, and that, you know, they're a skilled allergist that has had that discussion with you, in which case, awesome. Continue along the milk ladder, and when your allergist gets back to you, ask them when is it time to recheck for sensitization and to do a challenge to see if my kid has now outgrown the problem. On the other hand, if this isn't somebody who has gone through that process, has taken a history saying, okay, well, my kid's got tummy cramps from drinking milk because I've actually got lactose intolerance, and the kid has also got a huge amount of eczema, and because of that they did blood tests and it showed a little bit of sensitization to all of those different foods, and now for no reason that person has been taken off those foods even though they were tolerating them beforehand, and now they're going through the milk ladder. That's a different story altogether. If that's the case, that person needs to have that conversation. And I really love that slide you put to you started with Idanet, because you said allergy is not a yes no answer. There's a puzzle that has to be built, and there are pieces that need to be put together, and you need to have the skills to build that puzzle, and you need to have the framework to build that puzzle. And so it might be that that kind of a person needs to be completely reevaluated from the beginning. What is the history? What is the sensitization? Am I 100% sure that this is an allergy or not? And if not, is it a time for a food challenge now because I have to do a food challenge because the person's been avoiding the food? So this is exactly the kind of clinical situation that we are dealing with all the time. And sometimes that's great and it's fun and it's wonderful. And in other times it's because we are fixing a mess that other people have made through diagnosing allergies poorly with just blood tests or skin prick tests and nothing else. We have more questions to highlight, guys?
Mike, there's another question that I think is important to answer. The question reads, is there a link between high IgE levels and risk of anaphylaxis? My oldest son had reactions years ago, but his IgE tests now were very high.
Yeah, so I am going to take that one on. Unless, Peter, you want to?
No, go for it, Mike.
So the simple answer, Karen, is that there isn't a strong enough link between the level of your IgE and your risk of anaphylaxis for that to be meaningful. There are people with very, very high levels of IgE who have mild reactions, and there are people with very, very low levels of IgE who have very severe reactions. So it's not, you can't say that because his levels are very, very high, he's automatically an anaphylaxis risk child. It really does depend on the history, what's happened before, whether you've got any of those underlying risk factors that Peter talked about, like asthma or an unknown food allergy where you don't know what it is, so you can't avoid it, whether you've had the condition of having exercise-induced anaphylaxis, which is a problem, if you've had previous severe reactions, those kind of things can really say that you're at a high risk of anaphylaxis, and those are the kids that we then say it's 100% necessary to have an EpiPen and an action plan and a medic alert and all of those kind of things, rather than simply just the level of IgE alone.
I want to also highlight a question. There's a question, is it possible to get a trainer version of the adrenaline auto-injector to train staff?
Oh, tell us about that, isn't it?
No, I want you to answer the question.
Holly, okay, so yes, guys, there is a trainer version of the EpiPen available, and the drag reps for that company are usually actually quite good with dispensing them and are very supportive towards helping people train other staff or people that might need to get hold of it. We can certainly look into if there's a way that people would like training devices, whether we can compile a list and send it to the company, but I don't think that we can guarantee that they will do that. But if there's people with severe allergies and they want to train or want to be trained on how to use it, I think that's something that they would also support. So please feel free to email if you're interested in that. So there's a really, really sneaky question here from Comaine van Sale, who asks the question, is the likelihood of anaphylaxis linked to allergen exposure dose? And Comaine is actually an expert on food allergy and food intolerance, and is asking a question that is actually very, very difficult and very complicated to answer. So there are actually two answers to this question. The first answer is, for people who've got a severe allergy to a particular food, you've got to avoid that food strictly. Okay, because there are people, and maybe even some of you know who you are, who could have a tiny, tiny amount of that allergen and have a very, very severe reaction. Okay, and because of that, which is very, very different from the type of problem we have with a food intolerance, right, which is where you have an enzyme problem or something else, where you can eat a little bit of the food and you have a little bit of a reaction, or if you eat more of the food, you can have more of a reaction. You can eat even more of that food, you can have more of a reaction. There's a clear dose-dependence relationship with food intolerances between eating the food and having the reaction. So if you have a little bit, you're going to be a little sick, and if you're a lot, you're going to be a lot sick. But for people with anaphylaxis, it's a switch that goes on and off. You go from being fine to having anaphylaxis within a couple of minutes, and that could be at a very, very low dose. So we tell people don't take any risks. On the other hand, and this is where it gets really, really complicated, every single person with allergy is different in terms of the amount of dose that theoretically could cause a reaction. And although that dose threshold can be very low for some people, it can also be quite high for some people. So there are some people who are allergic, in particular to things like eggs and milk, who can tolerate those foods either in very little amounts or even more likely in different forms that are more cooked. And that is the basis of the whole idea of egg ladders and milk ladders that Internet was talking to and referring to. So some of you have talked about being on an egg ladder or a milk ladder. So in that situation, there is still the possibility for you to almost, when you're on a ladder, to be going up to see where that threshold is. Now, we typically don't recommend that anybody does that unless their allergies were mild to moderate, and particularly if they were delayed type allergies. We don't tend to recommend that for most people with severe IgE-mediated food allergies, and definitely not for people with anaphylaxis. So this is not saying that that's a completely alternative approach to the whole food allergy thing. It's in a subset of people that can be done. And the other thing that's really important to kind of keep in mind with this idea about doses and allergen exposure dose is that even within that same individual, that personal dose that I have that might be relatively high might be different for me from day to day, depending on other stuff that's happening in my life. Am I very stressed? Have I stayed up the whole night and drunk too many tequila shots and have got alcohol on board and haven't slept? That's going to decrease my threshold to have an allergen. Have I done lots of exercise? Have I got a cough or a cold or a fever or something like that? All of these things can change that allergen exposure dose. So the bottom line is, for people with severe allergies, the likelihood of anaphylaxis is not linked to your allergen exposure dose. You must avoid that 100% strictly. For people with milder allergies, you may be, along with your doctor, in a process of exploration with a ladder or sequential challenges. And for people with food intolerances, go for it. Eat more if you want to, but you're going to suffer those minor consequences of whatever condition that is going to cause. But it's not going to cause anaphylaxis at a higher dose because it can't suddenly change how it reacts. So that, Kamain, thank you, was a very simple but also very, very complicated question at the same time, and I hope I haven't confused people too much. If I have, please go onto the website and look at our 3 basic brochures. What is allergy? What is a food allergy? And what is delayed type food allergy? Because that also will, and what is an intolerance? That will answer this whole area of discussion that we've just had. Guys, we've got just a few moments before we close, so please pick up questions and answer them. Thank you, whoever answered the question about is promethazine a good antihistamine from Rosvin. Thank you for your questions, Rosvin. I'm going to answer this question not with a no. I'm going to say yes, promethazine is a very good antihistamine. It blocks histamine, but it is a sedating antihistamine, so it has side effects. If this is literally the only thing you have and you are itching uncontrollably and you want to sleep, then use promethazine because it will stop your itching and it'll make you go to sleep. But that side effect of it putting you to sleep is not something that we want in chronic urticaria, in hay fever, or in food allergy reactions at all. For those particular settings, promethazine is not a suitable antihistamine. Guys, any questions that you can pick up and answer?
So Janira Gabriel is asking, Mike, can a workshop be organized for people who are caring for special needs children? Why I ask is the fact that I came across that people don't really know it's a reaction. They think it's got to do with the child's illness. It is also that special needs children have much more allergies. Oh, so is it also that special needs children have much more allergies than other? And Janira, I don't think that that's really, there's a link between special needs and having more children than other, or more allergies than other children. Can we organize a workshop for them, Mike?
Wow, that's a big ask. Let's start
Yes.
discussions online with the Allergy Foundation team. I'm hoping that, amongst you out there are people who want to become involved and to help us action all of these great ideas and project proposals that people have. So if you've got ideas and project proposals, please put them forward. There just aren't enough people to do all the amount of work that needs to be done. If there are people there who want to look at the issue of each year doing a campaign around the issue of allergies in schools and to support us with doing the rollout of that and helping us design the materials, etc., we can provide resources for many of those different things because that's our mandate. That's what we want to do. So feel free, if there's that or any other ideas, please just pop us an email and we'll see what we can and what we can't do together. Maybe we can make it happen. We'll do our best. I think, if I'm correct, Meg, we've hit our cut-off time. So I want you to just finish off and close and thank everyone. I'd like to thank all the audience for being here and for all our speakers and for you, Meg, for doing all the arrangements. I think you've got a handout to give away.
I do. This has been an absolutely amazing session. Thank you to our audience. Thank you to our panel of experts. And of course, thank you to our sponsors for making this possible. I am going to share my screen with the winners of today's prizes. Please just give me one moment. Congratulations to Ian Craig, Zanele Nibe, and Taryn Brown. Please remember that winners were randomly selected today. I will be in contact with these lucky winners to arrange courier and delivery of prizes. Again, I want to thank you for joining us today. We look forward to you joining us at the next session on the 31st of May, focusing on rhinitis and conjunctivitis. For any further information, please feel free to email admin@allergyfoundation.co.za. Thank you for spending your morning with us. For any further questions, reach out to us. Thank you so much. Have a lovely, lovely weekend further, and we look forward to you joining us at the next one. Reminder that the recording of today's session will be sent to you via email. Please be on the lookout. Keep an eye on your inbox. You should receive it within the next hour to 2 hours.